Go. Okay, we're recording now. Hi, everybody. This is Dr. Ed Park from Recharge Biomedical, and today we're going to talk about dental problems. I think we'll start with the interspecies variation. Teeth is an invention of the vertebrates, and basically, what we see is that the location even of the teeth varies. Of course, in mammals, it's in the mandible, which is the lower jaw, and the maxilla. But in some animals, it's implanted in the palate or other areas. So there's a lot of variation, actually. What we think of as normal tooth behavior is only particular to us. For example, in rats, the teeth continue to grow throughout life. Mammals such as ourselves tend to be diphodont, meaning we have two sets of teeth, our baby teeth and then our permanent adult teeth. If we happen to be more carnivorous, then we get those canine teeth, those vampire teeth. But ruminators, mammals that eat mostly vegetables, they don't necessarily have those kind of specialized teeth. Interestingly, elephants, kangaroos, and manatees have multiple sets of teeth, not just two. And the tusks of elephants and the horn of a narwhal is also a form of specialized tooth. Fish continuously grow their teeth like nails, and reptiles can grow up to 3,000 new teeth, which just replace the old teeth. And that's illustrated above me. A squamate is a scaly reptile, and basically, this tooth regeneration, new teeth are always growing in and replacing the old ones, which is interesting. Uh, what we see to the left of that is where the expression long in the tooth comes from. Through a combination of gum recession and actual growth, about an eighth of an inch a year, the horse's teeth grow longer. And that's where the expression comes, don't look at a gift horse in the mouth, meaning be appreciative even if the horse they're selling you or giving you is 10, 20 years old. So the teeth do get long, hence the expression long in the tooth. When I was doing OBGYN, often, not often, but occasionally we'd open up the ovarian tumor and we knew going ahead it was probably what's called a benign cystic teratoma. This is a germ cell tumor, and there's some debate as to whether it exists congenitally. But anyway, so you go in and there's like a big mass in the person's ovary. We take out that cyst or the ovary, and we find teeth in it, fully grown teeth like these molars to my left, which tells us one thing, that there is a program to regrow teeth. Now, some will argue that this is congenital. Of course, it had to be growing along with the person because a tiny little baby doesn't have a giant ovary like that. But nonetheless, it's interesting that there is this de-differentiation possible. Teeth can grow if the programming is correct. Above me is a particularly heinous tumor. These can grow in also male testicles and in the sacral area for some reason. And this is showing there's even hair, sebum, as well as teeth. This principle was recently described several years ago by a Columbia professor, J.J. Mao. And what he did was to put in rats and in humans, a scaffolding in the missing tooth area embedded with some growth factors. One of these growth factors shown above me, ALX3, which somehow stimulates WNT, which is a known de-differentiation protein or growth factor, and also VEGF, which is vascular endothelial growth factor. And what this cartoon is showing with a bunch of cartoons and arrows is that you're growing new teeth, which is astounding. And you can see the microscopy above showing ND, or the new dentin, and the old dentin. So you can really grow new teeth, which is kind of a breakthrough. So the quote is, Dr. Jeremy Mao has developed a growth factor-infused three-dimensional scaffold that has the capacity of regenerating an anatomically correct tooth in a span of 9 weeks. So how wonderful would that be to have to, unless you're a dentist, how wonderful would that be to be able to regrow your teeth? Let's get back to reality and the human mouth anatomy. What we see is that our first or deciduous baby teeth are 20 in number. And the numbering is 2.1.0.2. This is not an IP address. It just means you got 2 incisors, 1 canine, 0 premolars, and 2 molars for a total of 20. After they fall out in childhood, you get your permanent adult teeth, which number generally 32. Some people have more, but generally 32. And the addition is 2.1.2 premolars. What we see is a baby skull or a child's skull, and we see that those adult teeth are coming in and actually pushing in the deciduous or baby teeth. Tooth numbering is shown above me, starting from the upper palate or the maxillary teeth. On the right, they number 1 through 16 on the top row and 17 through 32 on the bottom. The cartoon to my left illustrates what's going on. This dental lamina is this sort of epithelial pluripotent thing that somehow grows teeth. First, your baby teeth, around 6 or 8 months, I guess, and then somehow it's reactivated or still there somewhere around 7 or 8 years when you grow your permanent adult teeth. A dental lamina, so it's a dedifferentiation. It's this ability to grow teeth. We have to assume that in the reptile it never goes away. Likewise, in the fish, the rat, there's something different about the dental lamina, and so that just tells us there are growth factors that can reprogram, dedifferentiate, as we talked about in the lecture about nerve regrowth. So what's shown here in this cartoon form is that to get to a tooth erupting from the jawbone, and the tooth is symbolized by this purple thing surrounded by the yellow. Basically, there are phases. You start out at the bud, and then the cap, the bell, then the eruption, and then the tooth. All jargon, but it merely illustrates that there is a process that can be reawoken. Of course, people generally don't like to see the dentist. It's painful, but of course, it's the lesser of two evils. Dental pain is excruciating pain. It's said that in med school, we learned that there are 4 really bad pains. One is a bowel obstruction, one is a kidney stone, one is a corneal abrasion, and the 4th one is a rotten eye tooth. That's those teeth right here. When it's rotten, it's just killing you. It's very painful. And I encourage you to watch this funny movie, Reuben Reuben. It's sort of like a screwball black comedy about this English professor who goes around the women's colleges trying to seduce co-eds. And in the backstory, his teeth are killing him. And so it's a really funny story. It ends hilariously in a way. And it just reminds us that as much as we endeavor to stay young and healthy, when you're 21, you want rock hard abs. When you're 51 or 61, you just want to keep all your teeth. And when I was doing the research, the National Institutes of Health say that people lose their teeth. If you start with 32, it looks like the cohort of 20 to 34-year-olds, they only have 27 teeth missing. They're missing 5, which is shocking. Of course, this is all comers, homeless people, people with AIDS, heavy smokers, drinkers. All these things collaborate to give you bad dentition. By 35 to 50, people have lost an average of 7 teeth. This is shocking to me as somebody, not to brag, I have all my teeth. Maybe I don't deserve to, but by 50 to 64, people have lost an average of 10 teeth, which is astounding. Maybe a tribute to the effectiveness of dental marketing. But anyway, so I just wanted to call your attention to the fact that it's a one-way street in modern dentistry. Every time something goes wrong, there's not really a lot of recourse to fix it or replace it. We're talking about mainly just yanking it, which we'll talk about in a second. So above me, I bring back the octagon. The octagon comes from my first book, Telomere Time Bombs. And it just reminds us that what look like different diseases is all the same process. It's all telomere erosion, stem cell mutation, and abnormal cell behavior, which manifests, I guess, in the teeth as periodontal disease and tooth loss. In the brain, it might be Parkinson's or Alzheimer's. In the heart, cardiovascular disease, etc., etc. Okay, let's go into basic tooth anatomy. So above me, we see the wonderful tooth. It's got a crown, which is really like the head, and it's got a root. And between the head and the root is the neck. Okay. The crown is comprised of enamel, this hard substance, underneath which is dentin. And then in the middle is the cavity, or where the pulp is. The pulp contains the vessels and the nerves, which are important to keep that tooth alive and healthy. The gingiva is the gums, of course, specialized mucosal tissue that comes in right at the neck, the place between the crown and the root. Enamel covers the crown, and something called cementum covers the root. So the cementum enamel junction is where the gums should meet. When you have receding gums, it means the gums are coming down, either because the bone is being degraded from inflammation and periodontal disease, or some other process such as infection or inflammation. Okay, so we got it, crown and root. Interesting, the root has 2, 3 roots, and sometimes it varies depending on where you're talking about in the anatomy. Okay, so what is periodontal disease? That just means stuff around the tooth. So what is around the tooth? We talked about the gums. Of course, there's also the bone, the jaw that the tooth is lodged into, the cementum, which is that tooth side structure, and the PDL. PDL is periodontal ligaments. So if you look here above me, it's reversed. I apologize for the lettering, but the bone has little collagen anchors, that little tethers that go across the gingira and anchor into the cementum. Okay? This is why after a root canal, after you have a dead tooth, a zombie tooth, it doesn't fall out because you still got the tethering. The bone of the jaw is still alive and these ligaments are still present. So you really want these strong tethers to keep that tooth in place. When you have advanced periodontal disease through processes that we'll discuss, you get recession of the gums. And this is a cascade, sort of like a vicious cycle of inflammation, infection, and tissue destruction. The signs of which can be bleeding, loosening of the teeth, and halitosis, of course, from bacterial infection. This tissue loss can lead to demineralization. We see in the cartoon to the left a diagram of the 3 aspects, the loss of gum from the neck down, okay? And then from the existing gingival border down where you can probe, the sum of which is the extent of the recession of the gums. Risks include, of course, smoking, diabetes, HIV, and changes in the flora. And of course, this points to the fact that it is an ongoing immune battle to keep bacteria that you want, that are not destructive, that are in balance in your mouth. The X-ray shows advanced periodontal disease, and what it shows really is that as the gums recede, we're losing that barrier to the outside world, and the bone itself starts to go away, which is bad. Okay, let's talk about the nerves of the teeth. Generally, when I do procedures in the mouth, you can see that there's many colors on the left of injection. Okay, basically, there's just a bunch of nerves that grow in, and if you want to numb up, there's 2 big ones. One is the infraorbital, where you shoot up here, and that's shown right above me. And then one is the inferior alveolar, which is kind of illustrated to the left. But if you really want to numb up the mouth, arguably you need to do multiple injections, and that's something that we do when we do a dental exosome injection. There are 6 common dental procedures. One, of course, fillings for cavities. That's something not sure why, but when I was a kid, I probably didn't have great oral hygiene and ate a lot of candy. I don't think the teeth are as strong either as a child, so I had fillings, multiple what they call amalgam fillings, which, arguably could be toxic and releasing mercury throughout life. As we'll go into my case later, these fillings can get loose as the demineralization of the bone happens. But fillings is a pretty common thing. They drill it, they fill it. Now they use more of a ceramic thing rather than the metal or the mercury. Common procedure is also extraction. If something wrong with the tooth, yank it. And that's why those numbers start to come down to the 28, 26 as we get older. People just pull their teeth. Crowns are shown above to the left. A crown is when they put an artificial cap on the existing tooth. Next is a bridge. If there are missing teeth, 1 or 2, we see a double bridge here. What they'll do is put a crown on the existing teeth, okay, so that's damaging to the existing bridge holder, and then they'll put 1 or 2 artificial teeth, which are segmentally fused to create this sort of partial denture. Of course, there are dentures as well. So that's crown, that's bridge. An implant is shown above me. An implant is a multi-step procedure. They extract the tooth and they put an implant in, zirconia or titanium, and it has to fuse to the bone. Even though it's a screw, it has to be ingrown. And so after about 4 to 6 months, they'll put an abutment in, which is the link between the implant itself and the crown. So that's the gold standard of dentistry, is to just replace your natural teeth with implants. Also, there's a root canal. When you have a serious infection in your tooth, really the standard of care is that there is no medical or antibiotic treatment. They just got to do a root canal. And that stands to reason. Bone infections in general are not anything to be played around with. Osteomyelitis is bad, and it can lead to a cascade of further infection and even sepsis and death. So what they do is they'll go in and they'll drill out the entire root canal, and they'll remove all the natural pulp and all the nerves and the vessels, and they'll fill it with this rubber called gutta percha, which is what they used to make golf balls with 100 years ago. And so they'll also sometimes put a post to support it, and then after a time they'll come back and put a crown. And so you are stuck with mostly it's a dead tooth, but it's still wedged in there. It's still held in there by your periodontal ligaments, and you have a crown. So none of these are really that great, and that's why people say in the language, well, it's like pulling teeth, or I'd rather have a root canal. This is not a delight for anyone. So in general, you want to have good bone health if you want good teeth. That stands to reason. As we see in the octagon above, good bone health, less problems with osteoporosis, but all these aging processes, whether they be in the eyes or the heart or the vessels, it's all ongoing. So some degree of tooth decay, just like lung decay, just like everything else, is inevitable. The teeth are alive, but they don't need to be, as I discussed in the root canal, and they are constantly eroding mechanically and chemically. We have, stuff going on, chemical reactions. So the tooth, unlike the clever little rat, which can keep on growing its teeth, or the fish, our teeth are permanent, and they're not made to last forever. Um, but if you want good, healthy teeth that are not loose, you want to have good, healthy bones. Interesting, I was listening to a talk by this dentist about bisphosphonates. And bisphosphonates are drugs allegedly supposed to help with osteoporosis, but it's been a known complication that extraction and implants are nearly impossible and associated with a huge risk of osteonecrosis, meaning death of the bone, if you're taking bisphosphonates. So that means these terrible drugs, they're not really natural. What they do is they inhibit the osteoclasts. They literally poison the osteoclasts, which are half of the equation, the yin yang, the growth and destruction of the bone. So it disturbs the metabolism of the bone, can cause strange fractures in the length of the femur, but it can also cause unhealthy bone. So in order to see if you're a candidate for implants, they have to actually check something called C-terminal telopeptide, or CTX. And if that level is too low, it means there's insufficient metabolism in the bone to even take an implant. So that's something you should note if you are on a anti-osteoporosis drug. And also the physician was saying that vitamin D can impair CTX levels. So vitamin D, even though people think it's good for the bone, can also impair significantly your dental outcome. My dear mom, who I just saw and treated last week, is a big fan of oral hygiene. I think she's onto something, and more literature comes out every decade about the importance of oral hygiene. She always talks about gargling with alcohol and preventing all manner of problems in coronavirus. But there is some indication that things like Alzheimer's, cardiovascular disease, chronic inflammation could be related to poor oral hygiene. Gingivitis is, low level baseline, always happening. There's always some irritation in our mouth. Our mouth is second only to the rectum in being filled with bacteria. Actually, the vagina is very clean because it has lactobacilli that create a hostile pH 4 environment. Stomach also is very clean because the acid kills the bacteria, but the mouth, not so much. The things that we were taught in emergency medicines, if you're bitten by a human or a dog, you got to take that really seriously because there's so many flora in the mouth. Okay, so what happens with gingivitis is that you have this tartar slash plaque buildup. It's just a biofilm that becomes somewhat calcified. It's bad, and that's why people do the dental cleaning. But keep in mind, they have to take antibiotics when they do dental cleaning because some low level of bacteremia or seeding happens probably even when you brush your teeth. In other words, the mouth is so filthy that we can get endocarditis or infection of the heart valves, and we get low level inflammation, release of LPS, which is lipopolysaccharide. That's something in the gram positive wall of the bacteria. It can cause this ongoing constant inflammation. So, oral hygiene is probably accelerant, at least, to aging throughout the body via inflammation and infection. Things that impair oral hygiene are things that dry the mouth, mouth breathing, drugs that give you dry mouth. Um, Getting older, everything is less healthy. Diabetes, stress, all these things have been tied to poor oral hygiene. All right, so I'm going to talk about my own case. This is not me, but it was similar to me. As a child, I had multiple fillings in my molars, amalgam fillings, and uh, at about age, I'm going to say 41, one of the fillings fell out, perhaps because the enamel was deteriorated and the thing just popped out and it hurt. So, wanting to save money, my parents took me to Tijuana and we got a dental replacement. It was a ceramic replacement, but I don't think it lasted that long. And in about 8 years, it fell out. So, 3, 4 years ago, I started having pain recurring right here on the gum in front of tooth number two, which is the second molar. And so every month for about 4 or 5 days, it would hurt, and there'd be a fluctuant or kind of fluid-filled little bump of a few millimeters, and I would take antibiotics and would kind of die down. But it was like a monthly recurrence. So I finally said, "Well, I don't want a root canal. I got to go to a dentist." I went to my local dentist, and he said, "Well, we got to have a root canal." So I don't want a root canal. I hear all these bad things. People are saying they have brain fog and chronic health problems, and I don't know. Why risk it? Why not just fill up that hole that's leaking bacteria into my jaw? He said, "Well, that's just not the standard of care." So I had to actually, luckily, I found a nice, young, open minded guy. And I had to write this extensive letter, part of which is here, where I said, "I, Edward Park, MD, accept any and all risks, including but not limited to a rotten tooth, infection of the bone, adjacent teeth, sepsis, and even death. I hereby give my complete and informed consent for this procedure, knowing that the dentist advised me against this course of action and accept any and all consequences of the procedure." And this is something I tell people too. Sometimes you have to kind of treat your doctor or dentist like a tailor. Just give them what you want. You look silly, you got long pants or short cuffs, you just got to ask them what you want. And as long as you massage them in the right way and say, "Look, it's all my fault, I'm an idiot," they'll do it for you. And so he did actually put in filling, and so the leaking subsided, but I still continued to have occasional problems. It wasn't a full on open sewer into my jaw, but still problems. So a year and a half ago, when I started doing exosomes, I thought I would inject this area, and that's really what I did. Without numbing, I just injected the area with tiny bit of exosomes. And since then, I think in 19 months or so, I've only had one recurrence of a little tenderness, but no full blown abscess. I mean, it used to be the point where it would drain out, and it was bad. So I think that somehow helped me. Second patient is a dear friend here in Hawaii, AM, and she's 59. She has severe dental problems. Of course, I have to say, exosomes are not FDA approved to treat dental problems. She lives a very stressful life. She spends, I'm going to guess 4 hours on the phone every day for decades. That's part of her job as a realtor. And she usually holds it up to her head, although I've urged her not to. Above us, we see some kind of heat map of what the head looks like after using cell phones. And, the literature here is an entire topic on its own, but it's probably not a great thing to do. So anyway, she has gingivitis. She's had multiple root canals and extractions, and she says that every time she's really scared of the pain associated with it. We've done a dental injection, I think, once on her, and it really stabilized her symptoms. But even after she gets IV injections, she says that the teeth are less loose, they hurt less, and even the dentist said the gums are healthier. So, what would be the possible mechanism for that? Well, of course, exosomes signal remineralization, neovascularization, via vascular endothelial growth factor. They improve the tightness of the gingival barrier, perhaps, letting less bacteria, less inflammation take place. It could be shifting the flora to a more natural commensal flora. And then we could have better immune surveillance in the mouth. Who knows? Maybe all of those things are occurring. So that's really what I wanted to talk to. It's kind of a whirlwind summation of dentistry. And just to remind you, it's kind of a one-way path. We're all losing our teeth, and we don't want to. Perhaps in the future, we'll have this Dr. Mao treatment of regrowth of our teeth, and we'll be able to be healthy and happy with that. But I just wanted to give you a little insight into how exosomes might have played a role in improving our symptoms. So thanks for attending, everybody. Next week, we're going to talk about erectile dysfunction. And I want to put on my headphones and open up to questions in case anybody has any.
Yeah, yeah. I remember that Dr. I guess you said Mao at Columbia had done this pioneering work, but I think it was about more than 5 years ago. It feels like 10 years ago.
Mm.
And my question is, okay, he's made a breakthrough. Clearly, this can totally transform dentistry. But then I did, after a couple of years, I did another search and looked to see what the new work was. I didn't find any new work at all. So that whole project seems to have gone black. And like in defense contractors, they go black. They just secret. So what's going on? Has he stopped? Has he
I'm
gone
not.
out by Big Pharma? What's going on?
It's a great question. He's got two companies that he's founding, and when you're academic, sometimes there are issues of ownership of intellectual property. But I have no insight into what's going on. I just found it interesting at a superficial level that somebody had found a way to regrow teeth. I have
Yeah,
no.
well, I'd be interested in his companies. It's such a very promising thing. I just had a bunch of work done at USC, and I've got some of these little bridges and stuff, and they're a pain because they're hard to clean underneath the bridge. It's painful to clean them under there. You got to stick floss in there, and it hurts. So they didn't tell me that before they gave me the bridges.
Yeah,
So
I mean, certainly, I'm no expert in dentistry. I'm not an anti-dentite either, but they don't really tell you the downside of that. And so you
right.
have to remove uh, some things, some prostheses, you have to clean them, and you're doing damage to the adjacent teeth that are holding the bridge. So when in doubt, it's always better to keep your natural teeth. So,
I have a second question. I agree with you. The second question is that I found an article online from the Indian Journal of Conservative Dentistry,
mm,
and it was very provocative. And again, I've not heard any follow-up work. But I did talk to a dentist who was an Indian, and I said, "Is this a good journal, or is this a poor journal?" He said, "No, that's the best journal of Indian dentistry." And that's what's great. So what they did is they followed the root canal procedure you outlined in your slide there, and then they did a little extra excavation. They took, I think, an extra millimeter more than they needed because the concept was they wanted to make sure there was very little uh, bacteria in the dentin. I'm told that the dentin in a tooth is 15 or 30 miles long. A lot of tiny cavities and very long. So whatever the length is, it's huge. And so then what they did is with the top of the tooth off, they took a little steel dental wire, a piece of stainless steel wire, and they poked it down through the hole. So the whole thing has been cleaned out now, and they put in some chemical to basically, like a mouthwash to kill the germs. And then they poked the stainless steel wire down through the bottom of the root out into the tissue coming out the bottom of the tooth. And they stabbed around there in order to stimulate bleeding. And then the blood then kind of flowed up into the
mm,
tooth. And then
mm,
they put a temporary cover on it. And what happened is that the blood, which is around teeth, is just absolutely full of dental stem cells. And what
mm,
happened in a short period of time is that it regrew the entire structure of the tooth. That is to say, it regrew not only the blood vessels, but also the nerves. And you had a total internal reconstruction of the tooth. It's like Dr. Chow, the guy at Columbia, Mao's work. He used the guy in Colombia used an external matrix. These people in India use the tooth itself to be the matrix.
Well, it's the
And
first, yeah, it's the first time hearing it, but I mean, the same principle applies in the fenestration of the knee. Like, say you have no knee cartilage, what they'll do is they'll drill a bunch of holes in the cartilage and damage the bone, and the bone will bleed up, and presumably that inflammation and the native stem cells in the blood will figure out how to help regrow the cartilage. So that's a very interesting study. Thank you for sharing that. Makes sense to me, but that's the problem with dentistry. I think it's very filled with dogma, and the dogma is it's a one-way street. You know, you can't fix teeth because, again, as you point to, it's such a poorly vascularized area, and there's remaining nidus of infection in these little crevices. So it looks like they use common sense and a little ingenuity to try and really clean out that tooth and even fenestrate, if you will, the bone. I'd have to read that article, but yeah, I mean, that's the only way we make progress is by people thinking outside the box.
yeah, okay. Well, the journal was the Journal of Conservative Dentistry, and it was 5 or 10 years ago. And I can somewhere around I wrote down a note about it, but I haven't been able to follow up. And now with COVID and all, I'm not eager to go
Hmm.
travel over there to do that. But I found it provocative, and it really deserves publicity and support.
Absolutely. Well, thank you for sharing that. Yeah, I mean, I think the problem is that, as Upton Sinclair said, it's very hard to get a man, to understand
I've heard it.
something. Yeah, if his income depends on him not understanding it. So, because dentistry really is a procedure-based thing, um, I doubt that that kind of disruptive technology would be welcome by the mainstream profession. But if your goal is to help teeth regardless and help patients, then maybe that kind of new technology, either with the primitive bloodletting or fenestration, which you allude to, or with growth factors and dedifferentiation, like Dr. Mao, all of us that are not invested in sending dentist kids to college really want to have better options. So thanks for sharing that, John. I think that's enough information for people to web search it and find it.
Welcome.
Thanks. Any other questions? All right. Abby writes, I missed the first 19 minutes of your talk. I plan to see my dentist next week with a pus pocket. The teeth are solidly attached and not painful. I don't want a root canal. What do you recommend? Oh, yeah, I mean, I don't know. I mean, the problem is, you could take antibiotics, but once you get in the door, they're just going to read you the riot act and say, this is like one-way street. You got to get the tooth out. You got to get a root canal. And to some extent, that's probably true. It's not a really well-vascularized space that fights bone. And when you're talking about tooth infection at the root, we're talking about borderline osteomyelitis, and bone infections are really scary. But golly, I don't know. Anything you can do to improve your immune system, sleep better, nutrition, rest, maybe, I don't know, gargling with peroxide to keep the mouth closed or closer, cleaner, I'm sorry, or just regular mouthwash. You do have an immune system, and your immune system can contain, but in general, once you get into the establishment, there's no escaping. Sorry, I mean, there's a reason why people are afraid of dentists. Any other questions? All right, I think that that concludes today's webinar, and next week we'll do erectile dysfunction. And thanks everyone for attending. Sorry we missed last week. I was traveling, but I'm back, COVID negative, and ready to do more exosome webinars. So thanks everybody. Take care. Dr. Ed Park signing off.